it. How do I get it?
Rose, I think at this point, let's not worry about it. I think if we could have you on the camera, that would be good. If you can turn your camera on, don't worry about the background. It's irrelevant at this point. It's too late.
Okay, now the camera also is very fun.
Okay, when your camera can come back, that would be lovely. I think we are live now. Yes, Prof. Halim has joined us.
Yes. Thank you. Yes, good afternoon. Yes, Caroline.
Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Welcome, everyone. You can actively engage in the session through the chat box function. And for any questions you have, feel free to use the Q&A button in the bottom of your screen. We will address those questions at the end of the sessions. Now I'm going to hand over to Oliver.
Thank you so much. Good morning, good afternoon, and good evening. Thank you, everyone, for enjoying and joining with us today as we continue going through this webinar series. Today is the second webinar of 5 of the midwife-led birthing centers in low and middle-income countries. We are going to be talking about what is needed for the success. This is part 1. I'm Oliver Bazirete, a midwife senior lecturer and Dean of the School of Nursing and Midwifery at the University of Rwanda. I have been working with Novametrics and Barnett Institute for this project as one of the research team members. I just want to say that the slides are only in English, but we will be speaking to everything on the slide, and we are going to make sure we speak slowly so that the interpreters can make sure you are all aware of what we are saying. Before we start, I just want to take you briefly through the recap of session 1 held last week that focused on global overview of midwife-led birthing centers in low and middle income countries based on the scoping review and scoping and survey. Over 300 participants from all over the world attended the first series of these webinar sessions last week. Of all participants who attended the session, 61% of participants were from countries with midwife-led birthing centers. 23 of them are currently working in a midwife-led birthing center, and 65 expressed that they want to work in a midwife-led birthing center. A global scoping review and scoping survey presented during the first webinar session found evidence of midwife-led birthing center in 57 low and middle income countries, with a strong evidence in 24 low and middle income countries. There are many similarities observed with high income countries, with a few key differences. Midwife-led birthing center can provide high quality care when they are part of a well-functioning network of care with a positive policy environment, a purposive arrangement to meet user needs, an effective referral system, a competent workforce committed to midwife philosophy of care. I just want to take you through today's session's outline. We are going to talk about introduction and case study methodology. We are going to talk about success factor 1, which is an effective financing model. Then success factor 2, supporting and enabling leadership and governance. We are going to take a pool of questions so that we know what is going out there in your area with regards to midwife-led birthing centers. Then towards the end of today's session, we shall invite you to submit questions to be answered probably next week. I'm going now to present the methods used for our case study. To undertake our case study, we had established some selection criteria for countries to be included in the study. The country had to be from low and middle income countries region. Included the country had to have at least 5 functioning midwife-led birthing centers. We needed to ensure that in each country, there are midwife-led birthing centers in the public sector or were integrated in the national health system. We ensured that there was data availability for our economic analysis. We conducted a qualitative case study approach based on appreciative inquiry methodology with a focus on successful midwife-led birthing centers, what works and why, but not overlooking the barriers and the challenges. We had included the 4 countries from the 2 continents. We had South Africa and Uganda from African continent. We had also Pakistan and Bangladesh from South Asia. For the selection of the study site, 4 study sites defined as midwife-led birthing centers in this study were selected in each country. And it was based on a desk review of the literature and in consultation with the Ministry of Health, in consultation with Midwives Association, with National Research Team, the site managers, and other relevant stakeholders. To be counted as a midwife-led birthing center, a facility had to be a dedicated space providing childbirth care, where midwives were the lead professionals providing care. Specific characteristics were considered for the selection of the case study sites. So for each country, we included the site from both rural and urban or peri-urban area, with an exception of Uganda, where all the included sites were from the rural area. For each country, we had included the sites from both the public and the private or public-private partnership, with again an exception for Uganda, where all the 4 sites were from the private sector. For each country, we had included the 3 freestanding midwife-led birthing center and 1 on-site, also called alongside midwife-led birthing center, with an exception for Uganda, where all the 4 sites were freestanding. I'm now going to make a brief introduction on the high-level results from our study that we also call universal enablers and barriers. Today's session will focus on the first 2 enablers in a blue background on this slide. The first enabler for successful midwife-led birthing center demonstrated by our findings is sustainable financing. This is according to our findings. A range of financing models can be effective, including domestic, external, and a combination of financing models. Then the second enabler for the successful midwife-led birthing center is leadership and governance. This is about existence of policy, the recognition of midwives, the coordination, education and training, the monitoring and evaluation with regard to midwife-led birthing center. The third and the fourth identified enablers in a yellow background on this slide will be presented next week during the 3rd session. Our team will present on the quality of midwifery care and collaboration. Then the barriers in a green background on this slide will be presented during the other subsequent session. Thank you very much. I'm now handing over to Prof. Abdul Halim to take you through the first success factor, effective financing model. Thank you.
Thank you so much, Oliver, for the just giving me the scope. I am Prof. Halim from Bangladesh. We are just narrating some successes in Bangladesh, particularly focusing on the financial model, how the financial involvement in Bangladesh succeeded in promoting the midwifery services, starting from education to the midwifery-led services. Financing concern, the domestic financing, the government is the primary source, the main source of funding. Once we think of the education, beginning from the Prime Minister's commitment 2010, related to the UN Assembly commitment, the Bangladesh committed to develop the midwifery cadre in Bangladesh, and so started the 3 years diploma ICM standard course under the Nursing Midwifery Council, and the nursing colleges started with 20 public nursing colleges and 7 private nursing colleges, and initially and gradually it has been expanded and to the private as well as the government, and 62 government nursing colleges now currently delivering this education program. Beside the diploma course, also the BSc course is going on in some of the government nursing colleges, one private nursing college, and also the master course is on the way. So the education is going on. So the education is really completing the graduated midwives, and midwives are being registered at by the Nursing and Midwifery Council as well as the license as a midwife for service delivery. Since the service delivery in the government sector has been committed by the government and posts are created under the government since 2018, the numbers has been inflated until the this time around 2,557, and there are commitments of creating more and more posts, something 2,000, 3,000 plus another 3,000, and some sort of also commitment for the next 10 years, 12 years under the sector program of 10,000, 12,000 numbers to cover the total country by midwifery services. Though these services have been provided under the infrastructures, and currently the infrastructures, the primary care level, you know, for Bangladesh is the union level and the sub-district level. Sub-district level, the union level, there is 30,000 population, and then sub-district level is around 100,000 population, 200,000 population. So the midwife-led birthing center or MLBCs, these are the some standalone or some alongside this one. Upazila levels are the alongside, and mostly the union levels are the standalone one, mostly run by the midwives, led by the midwives. While all the investment from the government in the government sector, but beside that, the development partners, the UN organization like the UNFPA, NGO sectors, private sectors also investing in either the education, also the deployment, as well as the infrastructure and logistics. The private education is really a big bulk in our country. 108 medical colleges, nursing colleges are giving education to around 3,500 something numbers per year and registered by the nursing councils. And deployment under the private sectors are mostly in the NGO sectors and serving mostly the remote area, underserved areas, hilly areas, and the Rohingya areas or the camp areas. The Rohingya, you can say 400 to 450 numbers of midwives are now working on. The costs in the private sector for education, students are bearing. The cost is around $2,000 to $4,000 per student for the personal cost. The NGO service costs are mainly bear by the NGOs. For the out-of-pocket costs are very minimum because the NGOs are taking care of. Next slide. So the cost for MLBC, when you think of beside the education and the services, we have calculated the cost for 5 sites of our study sites. And these 4 sites, you heard from Olive that these are all primary alongside and standalone site. And one is the Rohingya camp site. And these are actually based on the salary, staff salary, and the facility operating cost, equipment cost, emergency transport cost. And then when the costs are taken into consideration, the birth number is the important factor per site. That is ranges from 100 to 2,000 numbers per annum. And then when the costs are taken into consideration, then cost ranges from $5,000 to $100,000. So per delivery cost ranged from $20 to $350. So the cost, if you think of compared to the standard rate of 100 women MLBCs, hypothetical cohort, it really in Bangladesh, our MLBC's cost is around $20,000 to $400,000. So this is the cost calculation per MLBC cost. Next slide, please. Next slide, please. Next slide. Can we go for the next slide? Next, yes. For whatever might be function, what are the work of the MLBC to strengthen the MLBC to minimize the cost financial things, collaboration is important and support is important. While the donor, UN, and the NGO partner professional organization is vital, either for the infrastructure or for the logistics support or support for the referral or the in-service training to uphold the skills of the midwives or the mentorship to increase the function of the program, actually mentorship program. So this is important. Most vital is the community linkage, community awareness program. So this is the bringing the women, increasing the number of births in birth center is very vital for those things. So this is really a vital thing for Bangladesh that makes a break to the midwifery service. And there is a big example that the collaboration with government, UNFP, and our organization, CIPRB, made a partnership for the voucher scheme where $25 given to the delivered women in a flood-affected division, where we have really by 6 months, 5,000 delivered women can be supported, and everybody is actually supported by the midwives and delivered by the midwives, and they have been connected through the midwives before the delivery, during the delivery, and after the delivery. And that was appreciated by, next slide, please. So the impact has been by qualitatively has been taken into consideration for evaluation, and really the women recognize their services provided by the midwives is really of quality, and the access has been increased and it is improved. And the community recognize midwife is essential, is required for their vicinity, for their services, for their maternal health. And government found the Union Center, this facility was underutilized, unutilized for the maternal newborn, this birthing services. But while these midwives are placed there, it becomes best utilized and better utilized. And this 4 MLBC really proved that women can be delivered, women's service can be delivered, and referral can be delivered, some complication can be reverted. And the SERP project, you know, the UN the relief fund can be utilized by 29 MLBC's centers, and 46% coverage can be done in that flood affected area. 21 referral can be done. So this project shown the effectiveness of this sort of midwife-led services can be supported if it can be linked with the community support system as well as the volunteer system and supported with some cash voucher system that is effective. Next slide, please. So to make this MLBCs or the midwife-led services to improve the maternal service at the rural area, community level area like Bangladesh type of countries in the world, we have to make the out-of-pocket to minimize. If the continuously government resources can be utilized in a better way, the fund can be continuously supported. Non-government funding can supplement and then can support all those areas, and per cost MLBC can be reduced by increasing births, clients flow, by connecting the community through outreach program or all the networking, whatever we are understanding, then the referral linkages and improving the transportation, either the boat or the human hauler, whatever you can say, the route communication, mobile or whatever networking. So everything is important. Besides that, since Bangladesh has already run around 10 years for the training from the education time, these midwives need a continuous process of upgrading the skill, retaining the skill. So some sort of competency taking, training program, mentorship program is important. Every point we need the financial involvement. If we can continue this process, it is a project, it is a program, it has the potential to show the example for reduction in maternal neonatal mortality rates. Would be a good thing for low and middle income countries. Thank you so much. Bangladesh lessons for everybody's thinking. Thank you. Next to Rose Nairobi.
Thank you. It's Dr. Rose Navide. I'm a nurse midwife educator, currently working at Ustema University. University and Uganda Private Midwives Association. Next, please. I have to apologize, my video failed to work, but I hope you can hear me clearly. So in Uganda, there is a supportive policy environment for the midwife-led birthing centers through existing policies which support MLBCs. For example, there is private-public partnerships. There is also recognition of the role of private sector, including that from MLBCs. The policies underscore the role of partnerships and collaborations, and there is strategic consideration of maternal and child health as a priority area. We can see from the quote here from a policymaker who said that the fact that they are able to contribute to offering maternity services to disadvantaged populations, so they improve access. That is very paramount. They improve access. Next slide, please. Yeah. The other one on governmental support and recognition, there is existing political commitment and will to work with MLBCs, and there are favorable systems in support of opening up MLBC practice. There is also provision of medical supplies to MLBCs, for example, mama kits, vaccines, family planning provisions, and so on. Another policymaker said, yeah, not all of them, but there are some commodities, like family planning commodities, which we give to them, and some sample commodities, selected ones. So they give to MLBCs. This is a policymaker from Ministry of Health, Uganda. Next, please. Yeah, there is also collaboration and coalitions. The MLBCs are integrated within the wider healthcare system. There is a recognized referral system for high-risk cases by MLBCs. And also MLBCs have memoranda of understanding with the referral sites, either private or public facilities. Next, please. Next slide, please. Yeah, there is also intelligence and oversight. So there is only service training of staff in MLBCs. For example, when they have continuous professional development, any other new policy, they train. They don't only train, they are trained by the public sector, mainly the Ministry of Health. There is also supportive supervision and mentorship of MLBC staff, and monitoring and evaluation of services in MLBCs. So they are monitored and supervised by the area district health officials, who are usually public officials. There is also community buy-in in support of MLBCs. So the policymakers, to ensure to support their commitment, one of them said the provision of guidelines and standards is by the government. Occasionally, if there are resources, they are called and given mentorships. Next slide, please. Yeah. There is also effective regulation. There is an existing legal framework in support of MLBC practice. The MLBCs are recognized as maternity homes in Uganda. So they are recognized and registered by the regulatory body, which is the Uganda Nurses and Midwives Council. The midwives are licensed and permitted to set up MLBCs. The minimum requirements of setting up MLBCs are not burdensome to the midwives. So many of them can actually open up their MLBs private practice. There is also transparency and fairness of regulations when establishing MLBCs. You can get these guidelines and the regulations for one to start. Next slide, please. Yeah, so in summary, for midwife-led birthing centers to be successful, there must be supportive policies in place. There must be political commitment for them to be supported and recognized. There must be collaborations and partnerships, public, private, NGOs, hospitals, district health officers for effective referral system and quality improvement. The government should play the oversight role, that is training, supervision, and mentorship. There must be a legal framework to ensure effective regulation of MLBCs. On the right, we can see signposts of MLBCs to show that they are established entities. And one of the regulations is that you must put a signpost to show what services you give and where you are with an address. So as you can see, they're established, most of them are established and they operate in rural areas. And they are successfully operating because of the above issues we have talked about. The supportive environment policies, political commitment, collaboration, and also oversight role and legal framework. Thank you very much for listening. Over to you, Rona.
Great. Thank you so much, Rose, for that fantastic overview, and for Prof. Halim as well. I'm hoping you can hear me. My name is Caroline Homer, if you haven't met me before, and I am one of the investigators on this study. I normally live in Australia, but I'm in rural Papua New Guinea at the moment, and the internet is not very good. So forgive me if I drop off, and Mandy Forrester from ICM will continue on if something happens to me. So I hope you have enjoyed listening to two of the very important enablers for successful MLBCs. Prof. Halim talked about financing, and there's been some good questions in the Q&A about financing and the different models and the different ways of financing. But clearly financing is important. And then Rose has just explained the really important messages around governance and policies. And unless we have the right policies in place, unless we have the governance support for private MLBCs, but also for public MLBCs, of course, we will not be successful. So we have a couple of questions now to ask you, and then we'll come back and take some of the Q&A that we have. So we'll just go to the next slide. And hopefully you'll be able to see a poll that will come up. So the question is, in your country, how is maternal and newborn health financed? Would you say that most women
Would you say that most women receive care that's free, provided by the public healthcare system? Do they receive care that's free, provided by a non-governmental organisation, a faith-based organisation, or similar? Do they have healthcare insurance that pays for their care? Do they have to pay for their care out of their own pockets? Other, or we don't know? If you'd just like to make your vote now, the poll will stay open for a while, and I see Caroline's jumped back on, thankfully, and she'll pick up the next question.
Let's just wait a few more seconds for people to answer, and I will share the results.
Thanks, Bruna. Thanks, Mandy. Apologies for that. So some more complicated questions this week than we had last week for you. Oh, very interesting. So 2/3 have free care. 1/3. Some of you have ticked more than one, which is perfectly fine. That is great. So it's very interesting to see the variation. So public's just a little bit further, but we have quite a lot of people paying for care through health insurance or paying out of their own pocket. So that's very interesting. We'll go on to the next poll, I think, Bruna. Okay, so this is one about policy. So again, picking up on the work that Rose just talked about. In your country, how strong is policy support for midwife-led care? And again, we'll have quite a few options. From very strong, somewhat strong, not very strong, non-existent, or I don't know. So this is about the policy support. And I guess by policy support, we mean the government policy support for midwife-led care. So we'll just wait for the poll results. Not very strong. It's quite high, almost half. 1/4, just over 1/4, very strong and strong. And 1/5 of you, 19% say non-existent. So that's interesting because it shows there's still a lot of work to be done out there. And I think there's also some messages coming up I can see in the chat about what the government policy might say and what the reality actually is, and not always the same thing, are they? There may be some differences, and that all of our countries have to provide very strong advocacy for the work that we do and for MLBCs. And we really hope that this study will be helpful to you, because it is now published, and we have put in the chat the link to the study. Oliver is the first author, and you will be able to use this study in your work and in your advocacy, we hope. So we might have time for a couple of questions, perhaps. I wonder, maybe there's some good questions, particularly around salary, and a question about how can we ensure midwives do the job correctly without a better salary. And I think that's a really important question. And that's a really important part of all of our advocacy, that we have to advocate for midwives to have better pay. So Prof. Halim, there was a few questions about financing. I wonder if you want to jump back on, particularly from Jen Stevens, about the freestanding birth centers in Bangladesh and how they participate in the public financing. I wonder if you want to just make a little comment for a moment about that, because clearly financing is so important and your work shows that. Are you still with us, Prof. Halim? Maybe he can't speak. Sorry about that. Right, let me just
So,
see. There,
thank you.
Prof. Halim? Yes, just go off mute. Yeah,
So,
okay. Just talk a little
the-
bit more about the financing for the freestanding centers.
Okay, the freestanding. So this is actually for Bangladesh. We are thinking of external one is particularly where the NGOs are working. The government is working also in the government sector where the deployment through the government appointments. So salary, everything is paid by the government. So these numbers are limited in the sense to until today around 1,200, but they are committed for year by years together will be up to 10,000. That is, it will take long time to cover the whole country, all the sub districts, means the unions. But by the same time, the NGOs are also working to support the country with midwifery services, where the midwife-led services are given deployment of the midwives, and particularly the Rohingya area also, the NGO sectors are deploying midwives even with the higher salaries, because these are very, what can you say, very the risk-prone areas where the usual midwife does not like to go there, stay in those risk areas, working in the very much, what can I say, the multi-language populations, and staying overnight together in that places, and then coming back to the districts to come back and also reside those areas. So this is to some extent, and also in the offshores and low-lying areas, the flood-affected areas. So NGO works in a very, what can you say, very underserved areas. So where the NGOs are providing those appointments. So those area actually we have some organizations, those are really giving appointments of the midwives, and they are working. But for the private sectors, the private organizations, they are as a business, they are appointing the midwives nowadays in their private clinics. This is the individual appointments, not as a structured MLBC. So they are working as for assisting the birthing women, but not like the structure of MLBC, what we are seeing in the MLBC of the government or the NGO-led MLBCs or the BRAC-led MLBCs. So this is so investments we can expect from the either NGO groups supported from the donors or the government sectors. That one is I want to mention here. But government still in the Bangladesh is playing good role, because we need the whole country to cover uniformly, and those centers are the really geographically covering the whole population. But definitely the pocket has to be covered by the UN or the donors fund. That is important.
Great. Thank you so much, Prof. Halim. That's really useful. And I think what it highlights is that the MLBCs that you set up have to be right for your context. And quite a few people have put in the chat and in the questions, which MLBC should we set up and how should we get started? And I think you have to do the work at your country level, at your regional level, and work out what's going to be right for you. There's no one size fits all. Rose, I might come to you. There's a number of questions about policy, about advocacy, about how to get started. Countries that haven't got MLBCs are wondering how to start. I wonder if you could provide some advice, some thoughts to our colleagues from around the world of how to get that policy piece going, how to get the leadership going. Are you able to jump on and give us some thoughts?
All right, thank you, Caroline. Yeah, how to get started? I think I heard you, Caroline, talk about advocacy. advocacy with the politicians to know that midwife-led birthing centers are very important, and they actually contribute a lot towards the reduction of maternal and child mortality and morbidity. So we can do this through the midwifery associations to advocate so that the governments get a buy-in. And of course, we have to do this with evidence. If the midwives attend to the women, and because in most cases the obstetricians or the doctors, they may not be there, and we can advocate that we can have the midwives run these birthing centers where the women can easily access them, so long as the midwives are trained. I don't know that that is some good, that it makes some sense, but we have to do a big advocacy, to play a big advocacy role here.
Yeah.
Yes. In Uganda, it started like in the early 60s, and they started by the midwives themselves who had retired, and they felt that they could still do something in the community. So that's how they started. And with the policies in the Ministry of Health, like the private-public partnership, that's how they have come to be recognized and even supported. So we have to do a lot of advocacy through NGOs like UNFPA and the other like JPECO, who are dealing with midwifery, to put the midwife at the forefront for governments to understand that they are very important. Thank you.
Thank you, Rose. I think one of the real challenges is, and we've seen it in the chat and the questions, about government policy that's oppositional to midwife-led care and midwifery-led birth centre. So it's a really difficult place, and that advocacy and that evidence and standing alongside, I think, is really important. Just a couple of resources. There lots of good resources have been put in the chat, and I encourage you to look at the ICM website for the first webinar and for policy and guidance on midwife-led birth centre. We also are working with the World Health Organization, with WHO, to develop an implementation toolkit. So hopefully the toolkit that will come out next year will give you some of the advice on how to do this. And we're taking your really good questions and making sure they go into the toolkit so that we can help all countries in the next few years do this. But I also encourage you to reach out to one another. There are some great networks. There's the Good Birth Network that I talked about last week. There's the WHO Community of Practice for Nurses and Midwives. I encourage you to join that. And then to reach out to one another. We have to do this as a community. We cannot do this alone. And it will not be one country that solves it. It will be, we have to do this across the world. So you are not alone. We really want to support you. ICM wants to support you, and your member associations will be a good support as well. Mandy, I wonder if you want to jump in here a little bit and say anything. We've got a couple of minutes left, and then we'll finish up.
Yes, thanks very much, Caroline. There's been some really interesting comments in the chat, actually. And one theme that I've noticed coming across is working with our medical colleagues and the opposition and challenges that we get. And the Philippines, Jerry in the Philippines has mentioned that that obstetricians are now being required to be at the birth for first-time mums, for primips. And my observation there is, as the Philippines has professionalized midwifery, maybe that challenge is is coming back. And we see that quite frequently, don't we, globally, that we really need to get our obstetric colleagues on side. The other comment that I thought was really pertinent was from Desiree Joseph, and she mentioned that women actually choose to have the care from the midwives rather than go into hospital because they get treated more respectfully. And I think that's another really important aspect that we can use for advocacy when we're trying to discuss this with women. I did put the link, and somebody else has put the link to the ICM enabling environment policy into the chat, and that's a really, really useful document. I actually use that quite a lot in my work as an advisor here at ICM. We also have the Respectful Toolkit there as well, and we're in the process of updating the regulation toolkit, which would really help countries that need to have some policy changes to enable midwives to work in this way.
Great, thank you so much, Mandy. That's terrific. Great to have those resources. So we're coming to the end, colleagues. Thank you for a wonderful webinar. I'm sorry we can't get to all of your messages. One question Helen has been asking about: what mechanism can ICM put in to regularize salaries? ICM works through your member associations. So Helen, whichever country you're in, please reach out to your member association, because that is where you will get your support. ICM can help the member association, but it's very difficult to say what a global salary for a midwife should be, and it's almost impossible, I'm going to suggest. But your member association can do that, so that's great. Bruno, I'll get you to put up the last slide for us. So today we heard about two of the main themes that we have been discussing from the study. Today you heard about the financing, and you heard about the leadership and governance, and that includes the policy. So next week, we are going to hear about two of the other success factors, and we're going to hear from colleagues in Pakistan and in South Africa. So Raviza Navid from Pakistan and Sheila Clow from South Africa will be joining us next week to speak. They're both here tonight, but they'll be talking next week. And two really key areas that have been coming up already are about effective collaboration. So this working with our medical colleagues, working with the other people in the team, making sure that we are midwife-led, but part of a team. And then, of course, quality of care. That's what we want at the end, don't we? We want mothers and babies in every country of ours to get quality of care, to reduce deaths, to increase lives, to increase well-being. So please join us next week. For some of you, the time will be a little bit different if your time zone is changing, you know, daylight saving or coming off daylight saving. So please look out for the time, and we will do it again for 1 hour, just the same, and we will talk about those two universal enablers and then take some more questions. Our webinar after that is about costing, and our last webinar is about how to get it into practice. So a huge thanks to our speakers tonight, to Oliver, to Prof. Halim, and to Rose. A really big thank you to all of you for presenting, and thank you to Mandy for being part of this as well, and to ICM for putting this on. I wish you all the very best, and see you all next week. Thank you, everybody. Bye-bye.
Thank you, Caroline. Thank you, Oliver. Thank you, Mandy.
Bye-bye.
Nice.
Bye, everybody.
Yeah, it's a nice presentation, and as well as nice work.
Yeah, really good.
Well done.
Yeah, thanks
Well done,
everybody.
everyone.
See you next week.
Thank you.
See you next week.
Bye.
Bye.
Thank you, Bruna,
Bye-bye.
for all support. Okay.
Yeah.
Sheila is fine. It's okay. All is fine. Sheila, thank you so much.